Today's brown bag talk, so I don't want to waste a lot of time, but just the usual administrative announcements. If you have devices that ring or buzz or vibrate, now would be a good time to turn those off. Please make sure you throw away all your trash before you leave this room. And finally, if you're taking the course associated with the brown bag, be sure to sign the sign-in sheet, which is over here on the podium. And with no further ado, I'd like to turn it over to Mark Bronstein to introduce today's speaker.
Pleased we have such a good turnout. I think this is an important talk for Georgia Tech and hopefully also for Georgia Regents University, within which is the Medical College of Georgia, the only public medical school in the state of Georgia. I've been on the Board of Visitors at GRU for the last couple of years and was very excited at the last meeting to meet Kevin Dellsperger, who just recently joined GVU, GRU. For anyone interested in health-related research, since the last time I looked, we didn't have a medical school. We didn't have any patients here on campus. We don't have much in the way of clinical data on campus. It's critical to collaborate with people who are out in the delivery of healthcare and have all those things. It's exceptionally exciting to have somebody like Kevin here, and you'll learn more about his background and interests. I think someone who would be a natural focus of collaboration between Georgia Tech and GRU. He got his Bachelor's of Science in Biomedical Engineering. There's your first clue, doctorate with an engineering background from Tulane. An MD, PhD from LSU. He trained in internal medicine and cardiology at the University of Iowa, was on the faculty of medicine and biomedical engineering there, became the chair of internal medicine at the University of Missouri, and he co-led the team that implemented their enterprise data warehouse, where all the patient data is brought together. You can see his current titles right there. Outside of academics, he's a senior member of the Malcolm Baldrige National Quality Award Program, a very prestigious thing. He's been funded by just about every imaginable federal agency, including the NIH, the Veterans Administration, as well as the American Heart and Diabetes Associations. He's published more than 125 articles of original research, and his interests are in the quality of care, the safety of care, and the integration of data and the presentation of data in ways that fit into the physician's workflow and practice, which is a particular interest of mine as well. So I'm delighted to have him here today, and I know you'll enjoy his talk.
Thank you, Mark. It's indeed my pleasure to be here today. It's been many years since I spoke to a primarily engineering audience. I was on the faculty at the University of Iowa and used to give lectures to the classes in biomed engineering, but it's probably been 15 or 20 years since I spoke to a group of engineers. The ability for me to speak to you is much less today than it was 15 years ago. You've moved much further along in your understanding of technology, and you've way bypassed my understanding of technology.
It's okay, most people don't consider us engineers.
Okay, well good. Well, when it comes to computers, my first one was a 8080, so most of you don't even, you'd have to go in the history books to see that one. But the reality is, as we go forward, what I want to do is when I think about the work that you're doing and the work that you will do throughout your career, you want it used. All of us want to leave a legacy. And that legacy for each of you in this group is seeing the work that you poured your blood, tears, and sweat in and making sure it gets used to help mankind. Regardless of what your definition of mankind is, you want to help people. And that's what I want to try to share with you. I want to create a case for the importance of the work you do, and I want to create stimulation for you to think in a slightly different way than you may have already thought. So we'll go through this journey. I'm going to get through this in a relatively shorter period of time. I want to go through it quickly. I want to have time for interaction and questions and discussion. So my objectives are to talk a little bit about patient safety in hospitals. I also want to talk about the public reporting and impact of quality and outcomes. We have at GRU a couple of unique public-private partnerships. I see that as a model to go forward. And we're going to talk a little bit about where the gap is. And I have no conflicts of interest to disclose. For you guys, that may not be something you have to put on your slides. For us in the world of medicine, we have to put that on our slideshows. So why is providing a safe environment so hard for healthcare? Well, this is a slide which shows a patient here. Oop, I was told I could write with this thing. A patient here having, well, I'm going to not write there. I'll use the mouse. This patient is having bypass surgery. For the most part, these people are the ones in the operating room. So from your system standpoint, those are the key players. These 2 pages of posters, and this was published in a Look magazine a number of years ago, and when you see the price in it.
Seeing your mouse, so just point
Okay.
it
Yeah.
on the button.
So this is the patient. This is the core team. All these people are necessary for this surgery to be successful. It is a total orchestration of activity. Any of these people fail, the system can fail, and you can have an adverse event. So most people don't understand when you go into a hospital, the orchestration of activity. You have janitors, you have maintenance people to keep the environment safe. You have multiple different kinds of clinicians. So all that is necessary for us to be successful. And that's a challenge. How do you communicate? How do you get information from one person to another in a way that they can use it? So I'm going to give you my own experience. About 2.5 years ago, 3 years ago, I guess, I was admitted to the hospital with gallstone pancreatitis. Gallstone formed, plugged the duct, got pancreatitis. I was in the hospital for 81 hours. It was over Easter weekend, was admitted on Good Friday, discharged on Monday, 6 hours after I had surgery. Had a gallbladder out, and 6 hours later I was in my bed at home. These are the doctors who touched me in 81 hours. Totally 7 attendings, 12 residents, and these are the different specialties. So let's assume that communication has to happen in a serial manner. And we have a rate of success of 99.5%. How many of you have played that game in a room where you sit in a big circle and someone tells the person next to them a line and it goes around, and by the time it gets back, it's nowhere close to what was said? I mean, that's kind of a fun game, particularly if you include some other things with it. But have you all played that game? Have you ever tried that? So is 99.5% a legitimate success rate? No. But even if it is, and we have stepwise, that's a 90% success that the message got across the whole continuum. Now let's make it a 2% error. We're down to 68. Let's make it a 5% error. And these are handoffs. All these people have to hand off to each other. All our rules and regulations about duty hours and all that stuff you hear about on TV are real, and it forces more handoffs. If a 5% error, and that's still really good if you played that telephone game or that that going around the room game, that's a 37% success. I will tell you, I was the conduit and the sole source of truth. I was telling members of my healthcare team what another member said. Now, I was awake, alert, and knowledgeable enough to do that. If it had been my mother, not a chance. In fact, my mother would call me and tell me what the doctor said, and I said, no way on earth he told you that. So the communication is key. Data is key. The amount of data in my chart in a few hours was about that thick of paper. Now, it was a lot of bits of data because it was an electronic chart, but it was that thick. So how costly are medical adverse events? The IOM report, which is quite old, but really is still standing the test of time, somewhere between 44,000 and 98,000 lives per year are lost because of medical errors. Not all of them are preventable. Some of them are. And I think if you think about preventable errors, it's probably closer to this. If you're talking about all errors, it's probably even higher than that. Health Grades in 2004 said up to 195,000 events or lives were lost because of adverse events. In Canada, adverse events in a study done a number of years ago reported 20% were fatal, and about 0.5% of hospitalized patients die of preventable errors. Now, what does a 0.5% mean? We have 19,000 admissions a year. So that's a lot of people. I like to think it's not that many in our hospital, but it's not zero in any hospital. But even if we took the lower estimate, we know how up in arms our communities are when you hear about a plane crash. That's the equivalent of a jumbo jet crashing every 4 days. So imagine the uproar of the public if we had jumbo jets crashing every 4 days. So what about Medicare patients? The Department of Human and Health Services study found a high rate of Medicare patient deaths due to adverse events. In part, we're doing a lot more to older people than we used to, and older people are susceptible to adverse events. Some of those are medication side effects and things like that. 15,000 patients experienced an adverse event during healthcare delivery that led to their death within a month. And in a OIG study, 13.5% experienced an adverse event. That could just be a drug side effect. So the adverse events are very broadly defined. However, they assumed 44% were preventable. If I don't give you the drug, you don't get the side effect. So that's preventable. Even though I might need to give you the drug to prevent the disease from killing you. So let's talk about the human components of safety. So when I was in medical school and early in my training, if you had an adverse event, it was your fault. You did something wrong. Why did you do this wrong? Don't you know better? People would be publicly humiliated in front of their peers at M&M conferences. And M&M is morbidity and mortality. So when you had a death in the hospital or an adverse event, we presented it at a weekly conference. And the person who had to get up and present, I can tell you, your heart rate was about 120, you were sweating, your mouth was dry, and your palms were wet. You were scared when you had an adverse event because all these professors are sitting there peppering you with questions about why you did this wrong. That was the mentality. So what does the public think about errors? In a poll, 1,200 citizens said we should publicize errors, should suspend the license of those who made errors. I tell you, If you suspended the medical license of everyone who made an error, good luck finding a doctor. Good luck finding a nurse, and good luck finding anyone else who's licensed in healthcare. Every one of us has made or will make an error, depending on where you are in your career. The hope is it's caught and prevented from harm. That's what the hope is. Government fines, and 25% said, let's have more lawsuits. So what about the new view of error? So that's kind of what the public thinks, that's what the old things are. So the new view of an error is the human error is a symptom of a trouble deeper inside a system. I showed you all the orchestration that's necessary. In the case of a patient for a bypass, I went into my electronic record with permission from my organization to try to annotate all the people who touched me. Not necessarily directly touched me, but indirectly. Pharmacists that filled prescriptions that I got, nurses, healthcare techs that took my vital signs, anyone who had anything to do with my care. I got to a couple of hundred people and I just got tired, and that was because that was the first 24 hours. I said, I'm not doing this. So I just focused on the doc component. So to explain failure, you don't try where the people went wrong, you try to find out how their assessments within the context of their system made them make the choice they made. So it flipped the paradigm. Errors are caused mostly by systems failures, and put people in a position to make the wrong choice or to not see the obvious. And I would contend to this group, not have the right data presented to him or her in the format that's usable and easily digestible. So this was the approach. So when you look at identifying the systems, the number one, when we have an error, we do something called a root cause analysis. And some of you probably do root cause analyses in your work. And we also use failure mode effects analysis. Now these two terms and these two processes that are pretty common in design and engineering principles and other components are relatively new in healthcare. It's really been in the last 15 years you hear about RCAs and you hear about FMEAs. Before that, never even in the lexicon of a healthcare organization. When we do RCAs, the number one, overwhelmingly by at least 2/3, if not more, are communication issues. And that is related to handoffs, standardization of communication, someone beating around the bush. Someone's worried about a patient, and they give you stuff that they think is communicating their fear instead of being very direct. I have a concern about the safety of this patient. Now, if someone told me that, my ears peak up. If they are telling me, well, so-and-so is doing this and this and this, I take that as, well, what are you telling me that for? But to say, I have a concern, my ears perk up, and now I'm listening in a different mindset. Documentation. This is where you guys come in. And the communication between disciplines and across power gradients. So what's a power gradient? I have a medical student on my service. The med student sees something that is an unsafe condition. They are terrified to come talk to me about it. They may tell the intern, who blows them off. They may tell the resident, who blows them off. And for me, I might have a cardiology fellow who might also blow them off. They will not go to me. That's a dangerous situation. It's something learned in the airline industry. Everyone in the crew has a voice. And when I start my attending rotation, I make it very clear I want everyone and anyone to identify safety potential harms. So I know, and we can intercede. When you get down to these, all these comprise maybe about 1/3 of the issues. Education or training issues, not uncommon for a new piece of equipment to be put in place, training to occur but so-and-so was on vacation and didn't get trained. So-and-so was sick and didn't get trained. And so now you don't have the entire team trained on a new piece of equipment. Or you've changed policy and you have to educate and train to the new approach. Equipment issues, sort of mostly related to training. Staffing issues. This winter has been terrible for us. Between the flu that hit in December, late November, December, going into January, and I don't know if this is, I have not seen that this is a rebound of flu again, but there are viral illnesses going around that are just decimating, I called it wave 2 of our staff. We have 8 to 10 nurses a day calling in, not being able to come to work. And that's putting strain and stress on those who can make it there. And some of them have just gotten well, and so they're really not physically able to work those extra hours. Fatigue or scheduling issues sort of tied in there, and policy issues. Sometimes we write stupid policies, to be blunt. So this is a Swiss cheese model of errors in healthcare. And basically, the whole idea is the holes have to line up for the error to occur. Somehow the translation of the holes made this line not be straight, but this is theoretically a straight line going right through there, right through there, right through there, through there. So, but the whole idea is when you look at a medication error in a hospital, typically 7 people had a chance to stop it. So that means 7 people failed. So you can have really hardwired systems, and one of the things is using barcode in medicine administration. That really stops a lot of them, but it doesn't stop the wrong order being written that seems logical to people all the way through. If it's the wrong medicine getting to the patient, you'll scan it and you'll get a red box, not a green box. But if I wrote the wrong dose, and it's close but not exact, it'll slide through the whole system. Well, he must know what he wants to do. Boom, 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 done. Even though all these people had a chance to intercede. So medical decision making is a little different. It's knowledge-based, slow response, significant thought. Medical students and interns function there, and experience-based, much faster pattern recognition. I'm a cardiologist, I read EKGs. It takes me on average 3 to 5 seconds to read an EKG. My medical students take 5 to 10 minutes. Now every once in a while I have to revert back to knowledge base when it doesn't fit my pattern. But I have enough patterns that I can get most of them done in 3 to 5 seconds. Error occurrence, applying incorrect knowledge, error in identifying abnormal patterns because you're tired or distracted. I read echoes. Yesterday I read echoes from 1 to 7. I got interrupted during the reading of probably 8 to 10 echoes. I've learned I go back to the beginning and read it again, because that distraction will take my pattern recognition and make it obsolete. And then I've basically got to reread it under knowledge base if I don't do that. So these are the judgment errors that we make. Strong but wrong rule, they're rules of thumb, but they got them wrong. It's a bad rule, the rule of thumb's not right. There's a confirmation bias. You're only looking at data that supports your hypothesis. You're ignoring data that refutes it. Overconfidence. I tell them I think it's X. I must be right. I don't have any hair and what I have is gray. So I've got to be right. And in reality, I'm wrong. Sometimes I'll play games with my trainees. I'll tell them it's this to see if they will challenge me. Because if they can't challenge me in a safe environment, I think they're going to have trouble when they get done. Availability heuristic. What you had last week is what you got this week, even though it's something you see once in a career. Premature closure. They don't leave a wide range of possibilities. They focus on one and forget the rest of the world. commission bias, and hassle bias. Hassle bias is a big one that you guys can help with. The systems stink. I'm going to do it the easiest way because it's less of a hassle. And that forces errors. So let's talk briefly about public reporting. CMS has been in this game for a while now, and it's something called value-based purchasing. And what happens is a hospital gets a certain amount of Medicare money, and they withhold a certain amount. In 2013 federal fiscal year, it was 1%. Federal fiscal year 2015, which we're in right now, it's 1.5%. And the goal through 2017 is 2%. Now that may not sound like a lot of money, but in a hospital it might get $400 or $500 million from there. That's coming off your bottom line. So 2% of 400 million is $8 million bucks. That's a lot of equipment, it's a lot of personnel for a hospital. So it's a sizable penalty. And the penalty can be significant. All the money comes off the margin. It doesn't come from other ways. So there are a whole host of measures. There's clinical process of care. There's 11 separate measures that account for 20%. Patient experience, this is patient satisfaction. The 8 domains are 30. Outcomes, there are 12 separate measurements bundled into 30. And efficiency, which was just added for this year, which is the cost of care for Medicare-only patients. And that's 20%. This shows you that it doesn't matter what I do today, I'm done. This is the baseline period for the fiscal year 15 data and the performance period. Notice the dates. Those are 2 years ago. I can't change anything about what's in the bank. I can only change as we go forward. So whatever we performed before I even got to Georgia Regents is what we're living with across the board. And I have to live with, it's like the football coach who cheats and leaves the university, and the university gets slapped with 30 scholarships. It's the poor schmuck that walks in with 30 less scholarships. The guy who cheated is coaching the Seattle Seahawks, right? Right? So what's our major challenge? Big data. It's huge. The amount of data that we have to consume as clinicians is overwhelming. We don't have time to look at it all. More importantly, we don't have time to interpret it. And the expectation from a medical legal standpoint and a clinical care standpoint is everything in that chart we ought to know. I can promise you there's not a doctor in this world that knows everything in that chart. Yet when you're defending yourself against a lawsuit, they will find the most minutia thing to throw at you. Well, doctor, it was in the chart. Why is it you didn't know it? That's almost an indefensible position. But it's reality. We need help as clinicians. We need a lot of help as clinicians. Because every time I turn around, there's more data. The amount of data I have to consume in the care of patients today has got to be 10 to 20-fold higher than it was when I started. And the complexity of that data and how that data means, and that's not even throwing into the equation a lot of this personalized medicine with genotyping. That's just regular stuff. Patients are sicker in the hospital. They generate far more data, more vital signs, more information that we can't digest. So we need analytics and presentation to the clinicians that are quick, easy to interpret, and able to take action. We also need a lot of decision support because the data is so massive. But the problem is patients aren't an industry of manufacturing. There are many parts of patient care that function like an assembly line in manufacturing. But at the same token, you don't have the tolerances, you don't have the forgiveness of some of the things you can design into a manufacturing process and you don't have the ability of your process to be that refined. Every patient has different needs. And how do you couple those needs with your decision making? You also need a huge framework for presenting this. And you need the information in a digestible, easy to retrieve way. So how are we at Georgia Regions trying to tackle this and eat this huge elephant, and we're just nibbling at it? But we're doing this largely through some public and private partnerships. And in part, that's one reason why I'm here after meeting Mark a couple of months ago. We have two relatively large partners, and you may have seen this in the newspapers over the last couple of years. One is with Royal Philips, and that's mostly a technology partnership, and I'll talk about each of the partnerships. The second is with our EMR partner, Cerner. So let's talk a little bit about the Philips partnership. The goals here are to help manage our inventory of technology. We realized as an organization we could not afford to get into the next generation of technology. Every time we would start catching up, we'd get derailed. And technology is advancing so fast. So actually what we did was we sold our technology to Philips. Philips owns all our equipment in our hospital. And they have to manage it to specifications, and we are getting state-of-the-art equipment. We're getting the second PET CT scan that's got some special whiz-bang in the world put in now. We would have never gotten that if we had to pay for it outside of this agreement. They're helping us look at an enterprise-wide view, not just a departmental view. So there are major incentives for us to stay with Philips family of product, if that's possible. They're integrating all vendors into the platform, and we're optimizing capital spend on new technology, not replacement technology. Most of that replacement occurred in that first year, and we're in the second year of this partnership. So our strategy is really to look at the big picture solution, improved integration. Philips needs a partner to understand how hospitals run. It's flipping the relationship between industry and us from one where it's essentially a transactional relationship. I'm here to sell you blah, and it's great. You ought to buy it. It's wonderful. All right, I'll buy it. See you later. Boom, I never see you again, because it's handed off to some other group in this huge conglomerate. And they don't know what this guy had promised you. And so it's been a frustrating relationship and experience for virtually every hospital. Now we have a problem. We have Philips people embedded within our workforce. They take care of it. They need someone from Germany to fly out to Augusta to fix it. Guess what? They're on the next plane. It's a much different relationship. So the responsiveness and accountability is there, and it's a predictable cost for us. We pay a unitary payment every year, and we get the equipment. There are things that can go up and go down, but for the most part, we have a reliable and predictable cost. This is really part of the relationship. It's technology management, which is the largest one. The managed equipment services, really technology management. Other equipment services, you know, all our monitors are Philips. Soon all our televisions will be Philips. All our lighting will be Philips. Some of our special rooms have very special lighting. I call it mood lighting, to help put the patient at ease and at rest. And we've used our patient advisors to help advise Philips what's the most soothing and comfortable for them. So Philips is learning from us, and we're getting the advantage of that relationship. We're also working on performance improvement and growth. So the model was more a transaction to now an overlap. So they're my colleagues. They have a GRU badge, and on the back they have a Philips badge. But they're my colleagues. They're my technology partners. So these are some of the things, and these slides will be available for you. I'm not going to read through all those. The second is the Jaguar Collaborative, and this is a public-private partnership with Cerner. And Cerner, as you know, is one of the largest EMR companies in the world, and actually Emory uses Cerner as well. The new normal is we're getting paid less for what we do. Healthcare reform is even changing that paradigm because it's now bringing the patient cost into the equation. So about 20% of our revenue is now expected to be collected directly from patients, not from insurance carriers. That's a less predictable recovery model. So how many of you have, I don't know, $1,500 to go get a surgery tomorrow? That's what your copay is, and that's what we expect when you come in to get your surgery. Most people can't pay it, so you got to put them on a payment plan. That means money you would have gotten last year or 2 years ago isn't there. And it cost you more to collect that money than it would have when you had your payers to work with. Aging population, physician shortages, and escalating costs. Everybody wants the newest, fanciest technology. Well, guess what? That's not free, and that's expensive. So when you looked at the mission and vision and values of the two organizations, they're essentially the same. Theirs is more of a global focus. Ours is more of a Georgia, but also some global focus as well. So why do this? Well, we had a large agenda in the area of IT. How many know about the term meaningful use in health IT? It looks like most of you have heard about it. Well, that changed our way in the way we implemented our medical record. It was a lot of money on the table. We weren't going to pass up on that money. So what it did was it forced us into an agenda from our IT department that really wasn't the agenda I would have set if I would have been CMO. But I wasn't going to turn around and look 20 or 30 million bucks to help support getting the whole agenda in away. And that happened to every hospital in the country that did meaningful use. We needed to improve, and we need to improve clinician workflow. I can't emphasize that much. And we need to improve patient safety and quality. We're capital constrained. We have difficulty in Augusta recruiting and retaining key people. Academic health centers do not pay executives in charge of IT the kind of rate that we need to. They're still working off the old, that's your computer system that runs around and makes sure your desktop works. And these people can move and make twice what they make in our system. And so this was a key part of getting the top talent we needed. Disaster recovery, huge. If you didn't think it was, you should have been in Augusta a year ago today when the place was shut down with the ice storm. Fortunately, all our systems were on a backup, and we use backup for days. But this will allow us to remotely host with triple redundancy of connectivity. And we're remotely hosting in a bunker that's, I don't know, graded way above an F5 tornado. Partner to handle automation of healthcare. We need to get this done faster than we would be able to do and limited growth of our operating budget. So Cerner is in Kansas City. It's at 10,000 sites in 25 countries. Their annual revenues are $3 billion, and they have 15,000 employees. It's huge. They're one of the top most innovative companies by Forbes, and they're one of the world's most admired companies as well. So they've created many public-private partnerships of different types. Here's ours, but I'm going to focus a little bit on this one, which is where I came from. And I was deeply involved with not so much the formation, but the initial operation of that public-private partnership. That's how I got involved in the enterprise-wide data warehouse when I was there. So when we look at our alignment, we're tightly coupled. This joint innovation with Philips is key. Philips has largely our technology, and what do we know about our devices is if it's not interoperable with our EMR, we're in trouble. There's a strong commitment between Philips and Cerner to have interoperability. And that's key, because I have to be in one system. I cannot be in more than one system. If I am, I'm not going to work in it. So let's talk a little bit about where the gaps are, because I want to leave time for questions. The biggest gap I see is the integration of all our data sets into clinical decision support, clinically meaningful visualization, timely presentation of data. I don't want data that's 3 days old. I need it real time. I'm taking care of a patient real time. I need it real time. It's got to be in my workflow. It's got to be in my nurse's workflow. It's got to be in my respiratory therapist workflow. If not, it's going to get ignored. And remember, these are key pieces of data we can't afford. And so why is this important? So I'll talk a little bit about Baldrige, and we'll talk a little bit about measurement, analysis, and knowledge management. This is one of the key categories for assessing an organization for the Baldrige Award. Actually, this is my favorite category. And the beauty is when I say that's my first choice, no one else on the team ever wants that category. So I always get my first choice. Either I'm stupid or very smart about picking that one. Because it's reproducible, I can get it. I'm on a team right now. No one even put that second on their rank list. So some poor schmuck got it to be my backup, though. So one of the things we look at is measurement, analysis, and improvement of organizational performance. That's data. That's key data. And management of information, knowledge, and information technology. This is the old-fashioned computer person in a hospital. Does your network work and that kind of stuff? This is management of knowledge and information. Some of it's digital, some of it's inherent in your workforce. When you have an employee who worked for you for years, they know so much more than what the job description says. And when they leave, you would go to Joe all the time for this problem, and Joe knew how to get it done. It's never been written down anywhere. So now Jack, who's taken over for Joe, has no clue. That's knowledge management. How do you transfer that knowledge? When a graduate student leaves one of the professor's labs, they bring with them knowledge that the professor doesn't have. How many of you are graduate students? A few of you. I'll tell you a secret my PhD advisor told me. At your dissertation defense, you know more about your project than anyone in the room. Don't forget it. They will ask you questions, but about your project, there is no one that knows more about your project than you. They can trip you up because they'll go peripheral to your project. They'll extend you, but I bet you guys don't have a 6-hour defense like I did. Yeah, I've heard of horror stories, but I had one, a 6-hour defense. One person kept asking me questions for 4 hours until I said, I don't know. And
It's your fault then.
well, I told him. He said, I've been waiting for you to say that. We're done. And I said, why didn't you ask me this question like 2.5 hours ago? We would have been done a couple hours earlier. And it was someone I knew very well. But he's thinking, God, he knows that. God, he knows that. Just ask me something I don't know first. He said, well, if you had answered that first, you might not have passed. So these are the properties of data. And I want you to think about this from your perspective, because from my perspective, this is key. Accurate, has integrity and reliability. How many places can I get a blood pressure in an EMR? Less than 2? Hands up. 2 to 5? 5 to 10? 10 to 15? More than 15? More than 15. Which blood pressure do I need? And they all could be a little different. Heart rates, not quite as many, about 10. Which one is the source of truth? And that's where the definitions and the mapping are so key. So key. Timeliness, we talked about that. It's got to be secure and confidential. You'll be in jail, you'll be penalized if it's not. Data and information has to be available as appropriate. I don't need to see everything, I need to see what I need to see. That's really hard for you to know what I need to see. I have to be able to express that in more than that vague term. I need to see what I need to see when I need to see it. That's not giving you a boundary condition in your design. That's giving you, well, we better make everything available to him in case he needs to see it. But this is where the interaction between the clinicians and the computer specialists are helping us define our views are so key. And getting good data on that. Knowledge management, collection and transfer of workforce knowledge, rapid identification and sharing and implementing of best practices. This is how we grow and how we get better. And assembly of knowledge to use for innovation. As you see more information, you actually become more creative. And especially if you're in a multidisciplinary environment. So this is big data. This is huge data. This is what you're working in. I put this up because I couldn't pass this up. This is the only thing technical I can throw on a slide. This is our data warehouse from the University of Missouri. And as you can see, our inputs are not just from the EMR, which is here, but it's from a number of different sources. Now I'm going to tell you, some of the sources that come from here are at odds with some of the data that comes from here. So it was a 2-year project from the time we chartered the team to the time we actually started getting reports out. A 1.5 years was spent by the group that worked right here, the data dictionary. The data dictionary is when you say blood pressure, which blood pressure. And in priority, if this one's available, use it. If it's not, go to this one. If this one's available, use it. If not, go to this one. We had to carefully do that. That required mostly technology-driven people with input from the clinical staff. Every element needed that dictionary. That was key and huge. Then we created data marts. Those data marts went through the dictionary, and our outputs came using a business objects background and Excelsius program dashboards that would come out in role-based profiles for the doc, the nurse, the staff, management. We had internet channels. We had this going to the patient. IQ Health at the time was our personal health record. And then public data we would publish straight to the internet. And this is an example of circa 2012 prototype of a physician level dashboard. Now, in my mind today, this is not good enough, and it's better now than it was, but when I left, that was the most recent version that I had. This was 2 orders of magnitude better than anything we had. It put a lot of information on one piece of paper and one screen. But it's not good enough today, and the amount of data is greater. So as you look at this and you go, well, this is actually pretty good. It tells you how I'm performing, how my group's performing, and what I'm performing against goal. It tells me something about individual patients. It tells me how I'm doing and my department's doing on a couple of key measures. That's not good enough. I can't make decisions, and that's just one. I can't look at 10 of these when I'm taking care of a complex patient. I need it all very quickly. So I'm going to skip through this. And this is what we're going to talk about. I sort of set it up, and now I'll open it up for questions and discussion. And I want to thank you for your attention. Yes.
I want to touch on a point you made earlier about the transition in the blame for what errors occur. And one thing you mentioned a little bit, but I wanted you to expound some more on, is the responsibility of those who design the equipment that gets used in the context where errors occur. And to what extent does the industry do anything to, I don't want to say apportion blame, but give responsibility to those people for having designed things that in the moment get misinterpreted?
So the blame for the design of our systems actually would probably work its way out through court if there were legal challenges against it. From my standpoint, if I'm seeing a recurring adverse event because of the technology we're using, either that company fixes it or they're out of the hospital. So that's a much easier decision for us to make. Now, it might be a very expensive out of the hospital because they got to replace it.
It's trickier for you, because what if Philips is producing a device that has a problem?
Well, we've already had that. We've already had that. So we go to Philips, and we put them on a real tight, part of our contract with both Philips and Cerner requires a certain responsiveness for safety events. So for example, if we have a patient safety event in a critical piece of equipment, they've got 24 hours to fix it for Philips. And Cerner, if they're installing software with a safety event, they told us under about 80% can be fixed within 6 hours. And I've been in implementations where they have a whole army of their computer software engineers on site as you're implementing. And when we implemented CPOE at the University of Missouri, within 24 hours we had 450 tickets filed for things that didn't come up in testing. Only when you get into the real live environment and the complexity of the live environment do you see it. About 20 of them were safety items, and as those were getting identified, some of them were getting fixed within an hour, and by the next morning, all but one were resolved. And then we continued to have them. So that's a little bit easier in those public-private. If you're doing this in a transactional-based thing, you're not going to have that kind of responsiveness. And I've seen hospitals implement and revert back to their old systems within a day or two because their implementation wasn't well designed. Yes?
So actually kind of a similar question I was going to ask before Gregory asked his, but not more future looking. So we move to the future with big data, data analytics, dashboards. The doctors will be seeing less raw data and a computer algorithm interpretation of the data. Does that frighten you at all? I mean, computer engineers, software engineers, let's be honest, don't have the best track record in delivering bulletproof, mission, life and death critical code always. Google, Microsoft, Yahoo are prime examples of that. How do you address those kind of issues?
I think that's a great question. There's going to, in part, how it's designed and how well integrated with the clinician, it's been all through the design phase. And I think EMR companies are a great example. First and second generation, even though good EMRs that were put in, were designed by computer software engineers and a handful of docs. And for Cerner, I can speak to Cerner because I've worked with Cerner now for 12 years through my relationship at the University of Missouri. The only docs they had on their staff were family practitioners. It was a well-designed record for a family practitioner's workflow. For a cardiologist, stunk. For a surgeon, really stunk. For many medicine subspecialists, stunk like it did for a cardiologist. It was what family practitioners needed, not what we as specialists needed. About 5, 6 years ago, their paradigm shifted. They realized their company's future depended upon creating a record that was valuable to everyone, not just family practice or primary care docs. The second question about taking all this raw data and turning it into information that we use, I think the proof's going to be in your own experience, in your group's experience about how robust it is. When I'm taking care of a critically ill person, and this is what I mean by the way some of it's displayed. When I walked into the ICU at the University of Missouri, there was a 48-inch monitor over the patient's headboard that showed all their vital signs in graphical format, a list of all their infusions with on and offs. If it was still being given, it was in green. If it was stopped, it was in red. I mean, highly visual, highly cued information. That's raw data. Now, I might go in and look at something else that gives me better decision support, but if I get called to the bedside with someone sick, I'm looking at raw data. I'm not looking at analyzed data. If I'm following someone in clinic, I want the benefit of assimilating all that mess into something snappy. Because you might be in clinic for an hour, I'm maybe spending 10 minutes with you. And if I've got to look at all that data, that's eating up my 10 minutes that I want to spend with you. So I need it in a snappy way. So there will be this dynamic tension between having raw data visually displayed in a manner that's very appropriate for the context of the patient situation, and then analyze data in the context of a different kind of stream of work. And we kind of bounce between different streams of work. Yes?
So this is kind of this same question. How do you see the quality control aspect of a data scientist that's looking at numbers and doesn't have a medical background or a full medical background, and the way they work with a medical doctor to interpret the data and to produce the analytics that are clinically meaningful?
So don't take this wrong. Some docs are geeks. Some geeks have a little doc in them. And I think you need the doctor geeks working with the computer ones in order to do it. Because I talk to my son, and I'm not a real doctor geek. I'm more of a doctor geek than many of the people at Georgia Regents. But I am certainly not where I would consider knowing some of my peers who can sit and do programming and all that stuff. I just know I want a program that does. So, and I know it can be done. You know, that's the level of my technological stuff. When I talk to my son, who now works for Cerner, within about 30 seconds, I don't understand a word he's saying. And I've had a conversation last night with him, because he's a diabetic, about his pump, and he's sitting arguing clinical stuff with me. And I go, well, son, when you finish medical school, your residency in medicine, and your fellowship in endocrinology, we can talk. I said, I'm not going to talk anymore about this. I know the answer to that. Now, about his own management of diabetes, he knows more about it than anyone, including his doctors. Because he knows how his body responds, and he's very analytical. He's got all this stuff in an Excel spreadsheet, and he's got all his graphical stuff. He brings it in and shows his doc graphs. And his doc loves it, because he's showing it to the doc in the format that the doc can make decisions. You know, he doesn't necessarily know exactly, he thinks he knows what to do, but he doesn't know exactly what to do. So it's really interesting, but it's got to be that interplay between those, and more of our medical students, strangely enough, have engineering backgrounds. They're very analytical. I think 25% of the MCG class comes from an analytical background. I mean, a highly analytical background. I was the only engineer in my medical school class. You know, I mean, it's pretty uncommon, but that's I think where we're going to have to go. And I think that's why Mark asked me to come and talk to you guys. You guys have to have an experimental partner. You can design all you want in your own, you know, laboratories, but unless you have someone who can advise you whether or not you're on the right track or the wrong track, and even if they tell you you're on the wrong track, not take it wrong, but take it as, well, this isn't exactly going to be helpful to me, then you can move into a new way.
I think
Yes.
we're at the top of the hour, so we should probably break here, because I know some people will.
Okay.
Hopefully doctors of Dellsperger will be able to stick around for a
Yeah.
few minutes and folks have some questions.
Come on up.
Let's thank them again.
Okay, thank you.